Thank you all for for the invite to speak at the PCCM core curriculum on this topic again. I presented on this topic many years ago. I think at the same core curriculum series. Not sure if anybody remembers at this point, but there's a lot that's happened. I think since the last that I presented this topic, which was before our institutional guidelines on neuroprognostication after cardiac arrest took effect. So just to start with a little bit of a historical perspective, the whole issue of neuroprognostication is in human history is a relatively recent thing. This is, of course, Napoleon's deathbed. In the past, it just wasn't that much of an issue. If you survived your critical illness, if you didn't just die immediately, then, well, I mean, there was the death watch, where people waited to see what you would do. More often than not, you would check out and leave. And there wasn't really any particularly compelling need for neuroprognostication. Whatever would happen, and more often than not, it would not be good. Obviously, things changed a great deal with the mechanical ventilator. Now you had the ability to keep people alive for prolonged periods of time, even in the face of dreadful critical illness, if the person survived that dreadful critical illness. And certainly prior to the 1970s, I think maybe the default was to simply use whatever forms of life support you could use just because you could. Certainly wasn't universally the case, but the idea that it's okay to not use life support is really something that picked up more steam, I would say, in sort of the late 60s and the 1970s. And what changed? What really sort of brought up this idea that yes, you can keep people alive for extended periods of time, but should you? And what is the right thing to do? For several reasons. I think the change happened for several reasons. One is the idea of patient autonomy, even if it's indirect. I mean, these are comatose patients, became a real thing. There was the idea that maybe the person really would not have wanted to be kept alive under those circumstances, and in continuing the use of the ventilator, particularly, really violating the patient's own autonomy and their own wishes for what happens with their body. Another thing that became a really big issue is the concept of futility. That if someone is in an irreversible coma and is sort of doomed to live this very poor quality of life, and if that's not something they would want, then the continued use of life support measures can be considered futile. This was also about the time that I think neurologists started to realize that there was coma, and then there was coma, right? There was coma that you're more likely to wake up from, hepatic encephalopathy, perhaps, or a variety of metabolic conditions where you're pretty comatose, but you're really going to wake up. And then there's coma that you're probably not going to wake up from. And there was just a more sophisticated understanding of coma, and just the early sort of understanding of how you might prognosticate in coma, with sort of the seminal work being Plum and Posner's book on the diagnosis of stupor and coma. It was also about the time that electroencephalography gained credibility as a bedside tool to assess brain function, and started to be used for the purposes of prognostication. Important sort of case to mention here is Cannon and Quinlan. I'm not sure how many people on this call will remember this case or know about this case. This is a young woman who suffered devastating hypoxic injury to the brain, was kept alive for many, many years. And in the 1980s or the late 70s, I think generated a debate on whether that was the right thing to do, because her parents thought that it was not the right thing to do, and that in the face of clearly devastating neurological injury from a hypoxic injury, petitioned the legal system for to be able to remove life support measures. Once the idea was established that removal of life support measures was a thing you could do and a thing that might be the right thing to do, the idea of neuroprognostication became much more important. And clearly the first tools used to try to prognosticate if someone was going to recover from coma or not was the clinical neurological exam. And the I think the earliest way to do this was the sort of the famous Levi criteria. For many years, this was what neurologists used to attempt neuroprognostication. This is the original 1985 publication of the Levi criteria. I'm not going to get into it too much, except to say that it's heavily focused on a couple of things. Obviously, it's brainstem reflexes, pupillary reactivity, heavily focused on the motor exam, motor component of the GCS, essentially, which is to say, what is your motor neurological response at a certain time point after cardiac arrest, typically 72 hours. There was also some attention paid to roving eye movements, and essentially, 2 or 3 criteria were identified, which were thought to very confidently predict poor outcomes at the 72-hour mark. The most important of which was the motor response to painful stimuli being, worse than flexion. So extension or none at all was identified as being particularly bad and probably incompatible with a good recovery. There's much that you can talk about these criteria, but really that's really most of historical interest. Even in the time period that the Levi criteria were being used, there was quite a bit of criticism about these criteria. And it's just interesting now from a historical perspective to go back and look at some of these comments about the Levi criteria. The exceptions to criteria for prognosis are not so exceptional. The number of patients in the poor prognostic categories were too few for a non-statistical power. The assessment of hopelessness and irreversibility was based on clinical science or unjustified early in coma and should not be communicated unqualified to patients' families. Much more data needs to be gathered before prognostic criteria can be developed that are reliable enough for application to individual patients. Now, the reason I selected these comments and put them up there is it's just striking how relevant they are many decades later. Here are sort of a quick timeline of the tools used in neuroprognostication after cardiac arrest. And you can see that the EEG is really one of the earliest tools that has ever been used in neuroprognostication. Almost this makes it look like it was used prior to the neurological exam. That's not quite true, but really the EEG gained credibility as a tool for neuroprognostication at about the same time that just a clinical neurological exam did. It is an old tool. Several other predictors have been looked at over the years: duration of coma, obviously that's the brainstem reflexes. And then as you get to the 80s, and then more recently, you see these other predictors gain prominence in trying to predict who is going to wake up and not wake up after cardiac arrest. So there's status epilepticus and myoclonic status epilepticus. There's biomarkers such as the neuron-specific enolase, measured from it's a glycolytic enzyme that's an isozyme that's specific to a limited number of cells, mostly the nervous system, that you can measure from the cerebrospinal fluid. Somatosensory evoked potentials, and imaging. Now, before we go on, let's just be clear about what it is that we refer to when we talk about a good outcome following cardiac arrest, right? And now there's many ways to grade that and judge that, but historically, by far the most common tool to judge a good versus a bad outcome after cardiac arrest is the cerebral performance category of the CPC scale. Now, it's not the only one, especially in this day and age. There's many other tools that are used extensively to judge good versus bad outcomes in cardiac arrest. The modified Rankin scale being a very important one. But it's important to know this scale. Really, any intensivist should know this scale. Just the basics of it. I mean, what's good and what's bad. So a good outcome is when someone is independent to activities of daily living, at least within the home. Another alternate definition is that they can hold down limited employment. That's not a necessity, but if they can do that, then that's considered a positive outcome. And independence and activities of daily living within the home are certainly considered a good outcome. So this doesn't say anything, for example, about cognitive outcomes, about psychological outcomes. And yet, I think most people would consider that independent. And when I say most people, I actually say that on the basis of research that's been done among people who are sick, not you and me healthy, but people who are sick, risk for illness. People seem to value people seem to value is the ability to be independent in activities of daily living. Of course, we all acknowledge that there's enormous individual variation in what somebody considers good versus bad. But when you look at entire populations, you have to draw some judgment somewhere. And this is the line that's drawn at the ability to be independent in your activities of daily living. And that is a dichotomy between a CPC of 1 to 2 versus a CPC of 3 to 5. So sort of going back on guidelines to neuroprognosticate, the first guidelines, systematic, widely used guidelines for neuroprognostication based on a systematic review of the literature were these guidelines. And this is the American Academy of Neurology's practice parameters from 2006. It's worth taking a minute to look at this. This algorithm here, I think, nicely summarizes these AAN guidelines that had such an enormous impact on neuroprognostication after cardiac arrest. Essentially, the algorithm goes that you, of course, must exclude major confounders. If you have no brainstem reflexes, then look for brain death, and it's certainly not a good situation. An important predictor that they identified was myoclonic status epilepticus, which is really an unremitting spasmodic contraction of your axial and appendicular muscles, basically your trunk and your arms and legs, that is unremitting despite measures that you might take for about 30 minutes. That's one definition that's been used. Other definitions include EEG, but essentially this is just unremitting myoclonic jerks, not in one part of the body, but your entire body is doing it. If that was present on day one, in the first 24 hours, that was thought to be universally associated with a poor outcome. False positive rate is 0%. Similarly, with somatosensory evoked potentials, which I'll talk about in a little bit more depth later, the absence of cortical responses was thought to universally predict poor outcome. Biomarkers, neuron-specific enolase from serum. I'm sorry, I think I said CSF earlier. Neuron-specific enolase from serum above a certain threshold was thought to universally predict a poor outcome. And then here's the big one, right? So the clinical neurological exam, the absence of pupillary or corneal reflexes, or an extensive or absent motor response at day 3 was thought to universally predict a poor outcome. These guidelines served as the basis for prognostication for a long time. This is what I grew up on, and this is what I applied through a good part of my career in counseling families and in prognosticating to clinical teams. Well, here's the problem with that. If you apply these guidelines strictly, by far the most important part of these guidelines are going to be this last thing right here, which is an extensor or absent motor response at 72 hours. Now, what that means is if you don't have a patient waking up, at least withdrawing, at least flexing at 72 hours, then you're going to prognosticate a poor outcome, and chances are pretty high then that a withdrawal of life support is going to happen. Now, the problem with that is all of the studies, or I shouldn't say all, but the vast majority of the literature after 2006, after these guidelines, have really raised some questions about whether, in fact, these predictors are as accurate as they were thought to be. So this study, for example, this is just an example, but of people who actually made an excellent recovery, who made a good recovery, a CPC of 1 to 2, a third of people who actually made a good recovery regained responsiveness after 72 hours, a full third. This is just one study. There's been many studies that have along the same lines that demonstrate that this 72-hour mark is just not valid. And we're not talking about a small number of exceptions. We're talking about a large number of patients who, given time beyond 72 hours, who may look terrible at 72 hours, but subsequently either quickly or very slowly do make a neurological recovery. This goes back to those criticisms of the Levi criteria, that the exceptions really may not be that exceptional. Since these guidelines were published in 2006, there's been a slew of studies that have identified several predictors that the guidelines consider to be excellent. 0% false positive rate, really not be that excellent. Some of the best data actually comes from the TTM study, which I'm sure most of you probably have heard of. This is the hypothermia versus normothermia clinical trial. Groundbreaking, excellent clinical trial. Also provided the opportunity to examine neuroprognostication variables. Just take the motor exam, for example. Perhaps one of the most important neuroprognostication tools. So the presence of an extensor or absent clinical response had a false positive rate in this trial of nearly 20%. So 1 in 5 false positive rate, which is really not trivial at all. I mean, that is a large number of patients as compared to something like the bilateral absence of the pupillary response, which only has a 2% false positive rate. I think what we've come to understand is that there's not truly anything that has a 0% false positive rate, but some of these predictors are much worse than others. I think this really sort of leads to the question, what went wrong? Right? I mean, these 2006 guidelines were enormously impactful. They were based on a systematic review of the literature. And so why did those guidelines go so wrong? What that has to do is confounding. And we know that this is a huge problem with every category of observational research, confounding. This is why we rely on clinical trials of restrictive versus liberal fluid administration, or pretty much anything else. This is why we find an arc change practice on the basis of observational data, because the best observational studies can still be confounded. What is the best predictor of death or poor outcome following cardiac arrest? Because this best predictor is surely going to be a confounder. The best predictor of death or poor outcome following cardiac arrest is the withdrawal of life-sustaining therapy. Comatose survivors of cardiac arrest will almost surely die if they are removed from life-sustaining therapy. And what we know now is that that entire body of literature prior to 2006, and a large part of the body of literature after 2006, including studies that are published today, are probably heavily confounded by the self-fulfilling prophecy. And what that means is that what is a self-fulfilling prophecy? This is a prediction that directly or indirectly causes itself to become true by the very terms of the prophecy itself, due to positive feedback between belief and behavior. Just to illustrate, what this means in real terms, I published a paper, I think, back in the early 2000s that looked at the use of these predictors in a resource-constrained setting. And what I found was that the AAN 2006 parameters, the guidelines, the predictors within those guidelines, absolutely reliable. 0% false positive rate, exactly as the guidelines suggested. The problem was that when I was working in this resource-constrained setting, my practice was that if I saw any of these predictors were present, I would counsel the family and say, hey, look, there's no responsiveness at all, no motor response at all. We know that this is a very grim sign. We don't think this person is going to do well. And then when you do that, the probability that surrogates are going to withdraw life-sustaining therapy is astronomically high. So essentially, you are creating a self-fulfilling prophecy, right? You're counseling that predictor is going to be bad, and so someone withdraws life support, and now you made that prediction true. And we published on that, and that, I think, reflects the problem with all of the evidence, exactly like the study that I published, that it was incredibly confounded by the self-fulfilling prophecy. Recognizing over the years that these predictors are not nearly as good as we thought they were, and that the 2006 parameters really needed an update, this was the first attempt to correct some of the problems with the 2006 practice parameters that had such an enormous impact on clinical practice. So these are the 2014 guidelines, I guess, from our advisory statement from the ESICN, where I'm not going to get into too much, but for example, the motor response, which was the big thing in the AAN practice parameter, was no longer considered to be an accurate predictor of outcome. Now, this is 2014, and in fact, there's been a large body of data that's accumulated since then that I think will further impact how we approach neuroprognostication. That brings us to the most recent update and where we are now. And so the most recent sort of very large scale project to address neuroprognostication are these guidelines. This is a collaborative venture between the Neurocritical Care Societies of the United States and Germany. The German Neurocritical Care Society is the DGNI. And this was a project that really did not address cardiac arrest alone. It addressed 8 important neurocritical care conditions. But the first and arguably one of the most important was cardiac arrest. Large panel. There were 20 members, and this guidelines used grade methodology. So I was the one of the leads of these guidelines. There's also the lead author for the cardiac arrest guidelines, and that's what I'm going to talk about today. What we try to accomplish with these guidelines was 2 things, and I'm going to deal with them, slightly separately. The one thing we wanted to do was to provide direct recommendations on specific variables that clinicians routinely use to prognosticate, to talk to families and provide an idea of what is going to happen to their loved one. So direct recommendations on whether each of these predictors should be considered reliable or not. The second thing that we wanted to do was to establish broad principles of neuroprognostication. So these don't apply to specific predictors, but these are broad principles that should be used when you approach neuroprognostication. Which specific clinical predictors did we select to write recommendations on? And how did we select those predictors? Really common sense, right? So the predictors that we choose to write recommendations on were those that this 20-member panel decided was most likely by clinicians to be used when formulating a prognosis and counseling families. And these are the predictors that really feature prominently in past guidelines, and that in the experience of all these individuals who routinely perform prognostication are used by a wide variety of clinicians at the bedside. It was also important that an appropriate body of literature was present. I will say, though, that bar was not set particularly high. For independent clinical variables, we really required only that 2 published studies where the sample size of at least 100 and a multivariate analysis be performed. And this was just for us to examine the predictor and write any recommendations on it. We also looked at clinical prediction models. Obviously, these are far more prevalent now than they were back in 2006. You all know what a clinical prediction model is. They incorporate predictors, the most promising individual predictors, to create a prediction model that is expected to do far better than any individual predictor. Most clinical prediction models in critical care are not used for the purposes of counseling families. They're used for quality control. They're used to compare apples to apples and oranges to oranges. Think Apache. But here we looked at the use of clinical prediction models for neuroprognostication. That's a place where you generally are not supposed to go with models such as Apache. Again, the bar was set pretty low for looking at these models, but yet we had to make a choice because there are so many of these. We really had to pick 2 or 3 that have been studied most widely and that clinicians are most likely to be aware of and potentially incorporate into their decision making. These are the variables that we addressed in our guidelines. I'm going to address each of them individually, but if you look through them, they're going to look very familiar. This is what I think the vast majority of clinicians will consider when they perform neuroprognostication. Of course, there are these niche predictors that individuals like to use based on their personal experience, but these are the ones that I think the majority of clinicians are likely to consider. The 3 clinical prediction models that these guidelines address are these: the OHCA, the CAHP, the GOFAR models. Now, the question that was framed to address these predictors was when counseling family members or surrogates of comatose adult survivors of cardiac arrest. So this really gives you the setting in a PCARS question. The S stands for setting, right? So we're talking about counseling here. You can address the reliability of a predictor for the purposes of QA, for the purposes of deciding on therapy, right? But in this particular context was counseling family members or surrogates of comatose adult survivors of cardiac arrest. Should that particular variable or model be considered a reliable predictor functional outcome, so not just life or death, which is entirely dependent on whether or not we continue life support. So really, good outcome, a CPC or functional outcome, 1 to 2 being good, 3 to 5 being bad, assessed at 3 months or later. This time period of assessment, which is the T in the PCOTS question, is extremely important. It's important for when you assess the predictor, but it's also important for when you assess the outcome. Much of the literature looks at predictors of outcome at discharge, which is enormously problematic when you're talking about neurological recovery, because there's a pretty good body of data that a large proportion of patients improve between discharge and 3 months. And many of the criteria that you use to decide if somebody has a good or a bad outcome, are the independent activities of daily living, that kind of thing, you can't assess when they're still in the hospital. So it's really absolutely critical that we consider a good outcome or a poor outcome to be something that was assessed not at discharge, but at 3 months. Now, obviously, outcome assessments in critical care in general are moving to later time points of assessment, think 90-day mortality versus 28-day mortality. But this is much more important in the terms of when you look at neurological outcomes. This is the PRISMA flowchart. In the end, we were working with 72 higher quality studies that support the recommendations in these guidelines. Before I get to the individual predictors, what is reliable, what is not reliable, I think it's actually valuable to first start with the general principles of neuroprognostication. And these are addressed through the use of good practice statements. Some of you might be familiar with what a good practice statement is in GRADE. They show up, for example, in the Surviving Sepsis Guidelines, which is another GRADE guideline. A good practice statement is something that, in essence, is self-evident and really doesn't have a lot of debate about it. It's not something that it's considered. In another way to think about it is motherhood and apple pie statements, mostly non-controversial statements that are just true. And these are what we used to establish the broad principles of neuroprognostication. The first good practice statement. Now, I will also say that yes, these are today considered to be non-controversial, but that's not to say that there isn't a rationale or data, publications, and evidence behind it. There are. And what I strongly encourage is, I'm happy to send it around when the guidelines are actually published. I think it's well worth looking at the body of data that supports even these good practice, non-controversial statements. So the first statement, we recommend deferral of assessment of the neurological prognosis of comatose survivors of cardiac arrest for at least 72 hours following return of spontaneous circulation in patients not treated with therapeutic hypothermia, and at least 72 hours following rewarming in patients treated with hypothermia. However, persistence of coma beyond this period in the intensive care unit must not be equated with a poor neurological prognosis. The second good practice statement, the second broad principle of neuroprognostication, is that we recommend that the assessment of the neurological prognosis of comatose survivors of cardiac arrest be performed in the absence of sedation or other potential confounders. This is an obvious statement, but it is something that needs to be clearly stated. Third good practice statement. We recommend that factors that impact overall prognosis, such as a poor baseline level of functioning, pre-existing illness associated with limited life expectancy, multi-organ failure, be considered prior to and distinct from assessment of the neurological prognosis of comatose survivors of cardiac arrest. To give you an example, and I'm not even really making this up, consider your end-stage ALS patient with metastatic cancer who's had their cardiac arrest and are comatose and under your care. In this patient, to be quite honest, neuroprognostication doesn't apply because neuroprognostication really addresses whether or not that person is going to regain independence in their activities of daily living. And this is someone who wasn't independent prior to their cardiac arrest. They were in pretty devastated condition prior to their cardiac arrest and was expected to die pretty soon. So in that setting, neuroprognostication is moot. That's what this says. It's neuroprognostication is all about what the brain is going to do to restore independence following cardiac arrest. It has nothing to do with an overall picture of what's going to happen to this patient. Good practice statement 4. We recommend that assessment of the neurological prognosis of comatose survivors of cardiac arrest be multimodal with consideration of the complete clinical scenario and picture, and never based on just one single variable. And that's because things can go wrong with one single variable, even if the literature suggests that that one single variable is an extremely strong predictor. And I'll kind of explain what that means as I look at the individual predictors. We recommend that in the absence of reliable or moderately reliable predictors of outcome, surrogates of cardiac arrest survivors who remain comatose at the time of neuroprognostication, which we suggest not be done before 72 hours, be counseled that the likelihood, extent, and time course of neurological recovery is uncertain. And this is when you don't have any specific predictors that the evidence suggests can predict an outcome. Surrogates should also be counseled that the timeline of any functional recovery that does occur may extend from several days to several months. Number 6, we suggest that an extended period of observation for signs of neurological recovery in comatose survivors of cardiac arrest with an indeterminate prognosis, if this is consistent with the goals of care as established through discussions with patient surrogates. This is for patients who at 72 hours fall into an indeterminate category. What is an appropriate period of observation? That depends. I think it depends to a great extent on the individual patient, what the surrogate is willing to tolerate, but it might range from 1 to 2 weeks to, for example, in your 18-year-old who suffers an overdose and is an indeterminate category where there might be a desire to wait longer and be more sure might really extend up to 1 to 3 months. Whereas, for example, a 75-year-old who suffered a VT cardiac arrest and has a relatively poor exam, but no definitive predictors of poor outcome. Not going to get into this too much, but this is a busy sort of table that lays down the technical criteria for which predictors were considered reliable, moderately reliable, or not reliable based on grade criteria. So here are the major grade criteria: risk of bias, inconsistency, imprecision, indirectness, and then there's the overall quality of evidence. I'm just going to touch upon this last column, which is the minimum point estimate of accuracy that was considered adequate. So for a reliable predictor, in addition to everything else in these preceding columns, it was required that these predictors have a false positive rate, that's 1 minus your specificity, of less than 3%. And the upper limit of the 95% confidence interval for a false positive rate be less than 10% in most eligible studies. A reliable prediction model required an area under the curve of greater than 0.8 and no evidence of miscalibration in external validation studies. And for those of you who know about prediction model research, that last criterion sets a really high bar, which with asking for the absence of miscalibration. Moderately reliable individual predictors, the bar was set lower. In addition to allowing some imprecision or indirectness in studies, the false positive rate threshold was set at 5%. For a moderately reliable clinical prediction model, the required AUC was 0.7, and some miscalibration, particularly in individual populations, was allowed. And then, of course, you've got predictors that are considered not reliable by themselves. This talks about the language that we suggest be used when using these reliable, moderately reliable, and not reliable predictors when counseling surrogates of cardiac arrest survivors. So when you have a reliable predictor in the appropriate clinical context, we suggest that the language is that a poor outcome, because that's what most of these things predict, is very likely, but you also must consider a disclaimer of uncertainty because there's no perfect predictor. And with reliable predictors, we suggest that the language is that uncertainty is present, but uncertainty is low. With moderately reliable individual predictors, we suggest that the language is that poor outcome is likely, but you acknowledge that substantial uncertainty is present. With moderately reliable clinical prediction models, more often than not, there's a predicted probability of outcome that you can use, but you must acknowledge that the predicted probability is an estimate and that it is subject to considerable uncertainty. So running through these clinical variables, let's start with age. The problem with age is that there's actually inconsistency in the literature about age cutoffs and how and when this is a reliable predictor. Most importantly, what is old age, right? I mean, there's just not any fantastic data about what is too old that you just, if you're in a coma at 72 hours, you're not going to come back at all. There's just no definitive data on this at all. And so what should not be surprising is the recommendation is that age alone, and I stress the alone, not be considered a reliable predictor of poor functional outcome assessed at 3 months or later. Initial rhythm, right? We all know that a non-shockable rhythm is associated with a worse outcome than shockable rhythms. This is true in the literature. The literature is consistent that a non-shockable rhythm is an independent predictor of poor outcome. Now, there is some imprecision in the literature, but the reason that we suggest not using a non-shockable rhythm on admission as a predictor of outcome while counseling surrogates, this context being important, is that your false positive rate can be as high as 40%. What that means is, sure, you've got a PA arrest, or maybe even an asystolic arrest. Maybe your time to ROSC was 5 minutes, or maybe you had excellent chest compressions, or maybe it wasn't. Maybe it was really more of a low flow state than a complete cardiac arrest. But whatever it be, you can't use a non-shockable rhythm alone as a reason to provide a poor prognosis when counseling family members. Time to return of spontaneous circulation, even better predictor than a shockable or non-shockable rhythm, right? We all know that there's a no flow and a low flow components to this. That the no flow component can be especially difficult to estimate, and we don't know. It's heavily dependent also on the quality of resuscitation and chest compressions. However, the data suggests that the time to ROSC is an independent predictor. The data is consistent. It's quite precise. But again, what threshold do you use? Let's take 25 minutes, which is commonly considered to be too long. Well, the false positive rate for a time to ROSC of 25 minutes might be as high as 32%, because there might be other mitigating factors. Excellent chest compressions. Maybe there's actually some cardiac contractility happening with these chest compressions. And so again, we suggest that time to ROSC alone not be considered a reliable predictor of poor functional outcome. So let's come to the best motor response. This is, notoriously guided prognostication for decades. And now, of course, we have a large body of data that suggests that it simply may not be as reliable as we thought. So there's inconsistency in the literature and a false positive rate up to 30% in more recent studies. Therefore, we recommend that the best motor response or a motor response of extension or an absent response not be considered a reliable predictor. However, the motor response is not useless. It actually can be very useful, because if you have a response of withdrawal, and certainly if you have localization, but at least withdrawal, the data suggests, including data from the TTM trial itself, that that's actually a pretty good predictor of good outcome. And that's got about a 93% sensitivity and a 77 specificity. So not great, but for predictors of good outcome, you can set the bar lower, because when you give a good outcome, you're not worried that someone is going to die. So it can be useful when you consider good outcomes. The bilateral absence of the pupillary light response, assessed at least 72 hours from ROSC, should be considered a reliable predictor. So here's the first of our reliable predictors, a poor functional outcome. However, this recommendation is conditional on accurate assessment without confounding by medication, hypothermia, or prior surgery, and an overall clinical picture consistent with severe widespread injury. So bilateral non-reactive pupils, which are not excessively common, but we do see them from time to time. In the absence of brain death, this is the one predictor that's really survived the test of time and continues to be a reliable predictor of poor outcome in the right context, as long as it's not because there was albuterol blowing over, that person's eyeballs. What's the problem with the pupillary light response? That you often get it wrong, right? So when you perform a manual assessment of the pupillary light response, you're often wrong, particularly when you decide that it's non-reactive. This was a striking study of neuro-ICU nurses performing pupillary light response testing, and only a third of pupils considered non-reactive by manual estimation was scored unreactive by a pupillometer. And that's obviously has tremendous consequence if we're using that as a reliable predictor of neurological outcome. We therefore suggest within the guidelines that if you have a pupillometer, please use it during neuroprognostication. It actually it is important because if you get it wrong, and people frequently get it wrong, that can have enormous consequence. If you don't have a pupillometer, there's other things you can do. You can call an expert, call an ophthalmologist, call an experienced neurologist, use a magnifying glass. There's other things that you can do, but you can't just take a one determination of non-reactive pupils at face value. The corneal reflex, on the other hand, is less reliable. The corneal reflex has a false positive rate of up to 16%. Which is above the criteria that we set, the predefined criteria that we set, which means that for the first time, we have guidelines that suggest that the corneal reflex is not a reliable predictor of poor outcome. Much of this might have to do with how it's tested. There's actually data that shows that even more so than the pupillary light response, the majority of neurologists may be incorrectly assessing the corneal response. Myoclonus, right? So the data on myoclonus was in fact far worse than we expected when we first began the systematic review. There was inconsistency, there was imprecision, and there was just almost no data on how the prognostic factor was assessed. So certainly the literature did not support the use of myoclonus in itself as a predictor of poor outcome. Again, this is change from prior guidelines, and has to do with a more rigorous examination of the literature. What is very useful though is, for example, this study. Let's say that you think that generalized status myoclonus is in fact a strong predictor. Now, the data doesn't necessarily support that, but if you assume that to be true, you still have to accurately identify it. This was a study of neurologists that suggested that neurologists actually don't do a particularly good job in differentiating myoclonus that may not be as serious from generalized status myoclonus. And that's an important thing to consider. If you're going to give a recommendation that this be used as a reliable predictor, are people likely to assess it correctly? And we could not conclude that that would be the case. Imaging, right? So evidence of anoxic injury on brain imaging. And what that is a diffuse loss of gray-white differentiation through the bilateral cerebral hemispheres, through the bilateral cortical hemispheres, and deep cortical structures. It's really important that this not be confined to one region. It's got to be bilateral. It's got to cross vascular distributions, and it has to involve both the cortex and deep structures. When you have this finding on CT or the equivalent finding on MR, that's considered to be a moderately reliable predictor of poor outcome. Now, why is it only moderately reliable and not reliable? For one thing, the best data comes from quantification of gray-white ratio using more advanced tools that are not available to clinicians at the bedside. It's kind of thing a radiologist does. Whereas clinicians are actually going to use just visual inspection of the scan. And so you have a little bit of indirectness that downgrades the evidence, and you also have imprecision because these studies are relatively small. Having said that, the false positive rate tends to be quite low. So this is considered to be a moderately reliable predictor of poor outcome. Same thing with MRI imaging, and instead of the loss of gray-white, here you look for restricted diffusion, which is just hyperintensity or white signal seen on DWI sequences on MRI images. Again, these need to be present bilaterally across vascular distributions in the cerebral cortex and the deep gray matter. They're assessed 2 to 7 days from ROSC. Again, there's indirectness because the best data is from quantification of the ADC of restricted diffusion. There's also imprecision because these studies are relatively small, but in fact, within these studies, the false positive rates are low. So we recommend that both these forms of imaging be considered moderately reliable predictors of poor functional outcome. Now, what's important to note is that MRI can be a pretty decent predictor of good functional outcome, in that if you have a MRI that shows no restricted diffusion, the overwhelming majority of those patients are probably going to do well. And that's what the data suggests. It's not quite as strong, accurate as the data for poor outcomes, but it doesn't need to be because there's not quite the same risk of withdrawal of life support when you provide a prediction of a good outcome. So here's what this looks like on diffusion-weighted imaging. EEG, right? So what do we look for in electroencephalography? We look for two things: suppression, which means that there's a definition of that your voltage on EEG is less than 10 microvolts for over 99% of the record, or burst suppression, which is to say that your brain is highly suppressed. There's very little activity for between 15 and 99% of the record. Now, you can have anything happen between these periods of suppression. You can have wild ictal electrical activity, all kinds of discharges, slowing, periodic discharges, doesn't matter. The question is it suppressed or not? You got to be careful because drugs obviously can cause suppression. Um, Other EEG findings that have been seriously considered as predictors in the literature and addressed in past guidelines, in fact, are just not as reliable. So just status epilepticus, for example, on EEG, there's multiple reports of people making a recovery from seizures, and even status epilepticus as long as the background of the brain looks okay. And then reactivity of brain waves to external stimuli was considered to be a very promising predictor, but unfortunately the false positive rate is really high, 44% in one study, so it's not something that we could consider to be reliable. This is what burst suppression looks like in EEG, long periods of flatness with some activity. I'm just going to skip past this because it's already at the hour. So we suggest that a suppressed or burst suppression background with or without periodic discharges on EEG performed at least 72 hours from ROSC in the absence of sedation or other potential confounders be considered a moderately reliable predictor of poor outcome. Somatosensory evoked potentials. There's just two more, I'll run through these quickly. Somatosensory evoked potentials, that's when you stimulate the median nerve in the upper limb and then study transmission of that signal through Erb's point here, through the cervical spinal cord, and then up in the brain, and look for an electrical response that confirms that the signal has actually reached the cortex. That's the N20 response. This is a testing that can be done at the bedside. If your cortical responses are absent on both sides, that can be a predictor of poor outcome. This is a very useful test as long as you can confirm that the signal is actually getting through all the way. I mean, think of the patient who tries to hang themselves. If you break your cervical spine and have an oxic injury, your cortical response might be absent because you've broken your spine. That's not a good thing, but it doesn't reflect what's happening in your head. SSEPs are not impacted by sedation and paralysis, nor for that matter is the pupillary light response quite as much, unless you're on anesthetic doses of some of these drugs. So it's quite useful even when someone's on propofol, on cisatracurium. Hypothermia will prolong latency, but will not abolish the response. You must beware of artifact. And if you have artifact, you should refrain from making a prognosis. But all that being said, the false positive rate for the bilateral absence of the cortical response in the literature is very low. And therefore, we recommend that the bilateral absence of the N20 wave with preservation of responses at Erb's point in the cervical spine on SSEP testing performed at least 48 hours from ROSC be considered a reliable predictor of poor functional outcome assessed at 3 months or later. This is conditional on accurate measurement and interpretation of the SSEP and an overall clinical picture consistent with severe widespread neurological injury. Biomarkers, neuron-specific enolase. Now, the data since the AAN guidelines came out suggests that the false positive rate for the threshold that they identified for this biomarker is much higher than 0%. And therefore, neuron-specific enolase, this is the first guidelines to suggest that, unfortunately, this is not a reliable predictor of poor neurological outcome. Now, maybe a much higher level of this biomarker, NSC, in the serum might predict poor outcomes, but that's just not been adequately validated in the literature. We also should be aware that NSC can be elevated through hemolysis, for example. So we should be really careful about making sure that there isn't either obvious or occult hemolysis. But until a threshold can be validated across centers, we did not think that NSC could serve as a reliable predictor. I'm just going to make it very quick about the 3 prediction models. Unfortunately, none of these had a sufficient body of evidence to support use in clinical practice. We suggested that these 3 clinical prediction models could be used the same way that you use your Apache score today, which is in QA, and to just get an idea of how sick your patients are for research or for quality assurance, but you can't use it to counsel family members that the patient's outcome is going to be poor. So I'm going to close off with a recommended algorithm that is included in these guidelines. So I'm not going to go into them in depth. You're welcome to actually look at this algorithm in the publication itself. But this goes through when you perform testing, and these are the actions that you perform in the first 5 days to work towards neuroprognostication. And then this algorithm is the new algorithm that we suggest for neuroprognostication. The way that it works is that the person is following commands at any time. They're awakening and you have a good prognosis. They meet criteria for brain death. Well, that's what it is. They're brain dead. If they have one of these 4 predictors of good outcome, these are the first guidelines to actually talk about good outcomes rather than just bad outcomes. If you have any one of these 4 predictors of good outcome, a motor response of withdrawal or localization, a clean MR, an EEG that becomes continuous and reactive quickly, then we suggest that you say that because these are imperfect predictors, we suggest that you say that the outcome is indeterminate, but a good outcome is more likely. Now, if you have one of the 2 reliable predictors of poor outcome, absent pupillary responses on both sides, or SSEP with bilateral absence of N20 waves, then we suggest that you use this language that I talked about, that a poor outcome is very likely, but that some uncertainty exists. When you have the moderately reliable predictors of poor outcome, which is imaging or EEG, then we suggest that we say that the poor outcome is likely, but that substantial uncertainty exists. And if none of these are present, then the outcome is indeterminate. Future directions, I think is with probably complex clinical prediction models facilitated by machine learning, EEG analysis facilitated by neural networks, machine learning. There's a lot of this work that's been done already, and so I'm sure this guidelines are going to look very different, hopefully 10 years from now. Sorry for going over time. I'm now 7 minutes over. I'm going to stop there, and if anyone is still on, wants to ask questions, I'm happy to take them.